Okay, so today I'll talk about ACL. So basically the function of ACL is to control anterior translation of tibia and also secondary restraint to tibia rotation lah, as well as valgus and varus stress. So anatomically, basically it started from, it originates from posterior medial aspect of the lateral femoral condyle, and then it goes anterior and medially and insert anterior medial aspect of the tibia between the condyle. So it has two bundles, the anterior medial bundle and the posterior lateral bundle. So blood supply is by the middle branches of a middle geniculate artery, and then the nerve is by the posterior articular nerve, which is a branch of a tibial nerve lah. So for the risk factor of ACL injury can be divided into two. So contact and non-contact lah. So contact is anything like MVA or high speed punya impact to the knee, or any sports that causes a direct blow coming from usually lateral aspect of the knee lah, then on lateral aspect of a planted knee lah, and causing hyperextension or a valgus to the knee. And then for a non-contact risk factor, it will be patient who previously has a history of ACL injury. The risk of re-rupture was noted as 6 to 25% lah. And then for female, due to their physical and biomechanical attributes. For age, it was mentioned that it was a younger population lah because of their earlier participation in sports. And for another risk is anatomical and hormonal. Mentioned that female has a larger Q angle lah. So, and another thing is because female has a serum estrogen and relaxin that cause flexibility and strength of the soft tissue. And then last one will be neuromuscular and biomechanical risk factor. Those who have a weaker hamstring, weaker core, weaker hip rotator will have a higher risk of injury, ACL injury. Next, we'll go into the clinical manifestation of ACL injury. So usually patient will complain of having a pop sound at the time of injury. So right after that, they will have acute swelling lah. Usually it's an effusion or hematrosis. And then after the swelling subside, usually patient will complain of knee instability, especially upon weight bearing activities, when the entire body weight is placed on the affected leg lah, or during squatting, pivoting, stepping laterally, or going downstairs. But usually they are still able to bear weight, just usually will complain of unstable. So assessment and diagnosis. So first we'll go into history taking, physical examination, diagnostic imaging, and the last one is of course knee arthroscopic diagnostic lah. So the first one, history taking, like mentioned just now, we asked about the clinical manifestation lah, the how is the injury, the mechanism, and then what is the symptoms right after the injury. And then for physical examination, we go to the usual one, inspection, look for any swelling if it's an acute setting, and then look for any effusion. Palpation, look for any tenderness around the joint line to rule out other ligament injury lah. And then also check the strength and subsequently stability. So for ACL specifically, special tests will do anterior drawer test and enlargement test lah to check for ACL. And then next we go into diagnostic imaging. So usually we still proceed with a plain radiograph. Important thing is to look for a Seagon fracture lah. So which is the avulsion fracture of the anterolateral tibia plateau at the site of attachment of the lateral capsule. So if ACL injury, we want to rule out this Sigon fracture lah. And then next one will be MRI. So MRI, we able to see the degree of tear of the ACL. And then if let's say our physical examination history and the diagnostic imaging contradict each other, there's a benefit of doing a knee arthroscopic for diagnostic purposes. So next we'll go into treatment. So treatment have acute management and later on subsequent management lah. So acute management, when patient come right after, if let's say right after the injury, usually we advise for RICE lah. Ice compression, elevation, compression and rest. And then if the leg is very unstable, patient can walk with crutches first and then also give patient analgesic. So once the if there is hematrosis, can advise patient for aspiration lah. So once the swelling subsided, we can do a proper examination and look for properly diagnosed as ACL lah. So the treatment will be either after the acute phase, it can be either operative or non-operative treatment for ACL tear. So if partial tear and patient doesn't complain of instability, doesn't affect ADL, usually can go for non-operative treatment lah, which is rehab, muscle strengthening, and then if let's say depends on the level of activity of the patient, functional demand, and then patient's activity limitation, let's say complain of locking or instability, and of course patient occupation lah. So if let's say all these come into account, we can refer patient for operative management. So next one will be the timing and preparation for operation. So the prerequisite for ACL reconstruction, usually we need the patient to get a full range of motion of the knee lah. And then when on examination, make sure there is minimal or no significant effusion. And then also for the muscle strength, have adequate strength for the quadricep and the hamstring lah. So pre-op rehab, usually we give about 4 to 6 weeks lah. So timing of the operation, it has to be optimum also. So if let's say premature, it actually increase the risk of arthrofibrosis and adhesion. And if too delayed, meaning like more than 3 to 4 months, it increase the risk of meniscus tear lah, because of instability. And then next will be a complication of ACL, for operation and ACL injury lah. So short-term complication will be infection, DVT, and the loss of joint mobility, unable to get full extension of flexion. And then for long-term complication, a patient can have a risk of OA. For ACL reconstruction, they can get graft failure or arthrofibrosis. So next will be prevention, ACL injury prevention program lah. Like how do we go upon this one to prevent ACL injury lah? So first one is a strength exercise. We advocate those who are active in sport to do a hamstring, hip, ankle stabilizer, and also the core strengthening lah. And then the next one is about instructor education. So it's good to give workshop or talk to the coaches so that they can educate the athletes upon correct, for example, landing mechanism and correct way of strengthening and doing exercise to reduce the risk. And then next one is for those who are active in sport, suggest to start training at an earlier age lah. Okay, it was mentioned that as early as 10 years old, they can start training for muscle strengthening. And then frequency of training can increase and get a frequency of at least 2 times per week. Okay. And then last one is about rehabilitation. So for post-op rehabilitation for ACL, so this is just a brief one lah. So for immediate rehab, we encourage full ROM for the knee, and then encourage closed kinetic chain exercises for hamstring and quadricep lah. And open kinetic chain exercise that are not stressing the knee can still be prescribed. For example, SLR, ankle pump, and quadricep contraction lah. But for a full open kinetic chain, usually we introduce after 6-week post-op lah for the knee. So I think that's all a brief general for ACL approach to ACL lah.